And I'm going to open the doors right now.
Great. Welcome, everyone, and good morning. Thank you for joining our webinar today. I know folks are still trickling in, but really appreciate the opportunity to share insights of our presentation today, entitled Expanding Community Wellness Hubs in Ontario. Before we begin, let's all take a moment to reflect the land that we are on today. As a settler who is privileged to reside and work on this traditional land, I would like to begin by acknowledging that today I am situated on the territory and Treaty 13 lands of the Mississaugas of the Credit First Nations. We at AdvantAge Ontario acknowledge that our work, along with the work of our members across Ontario, takes place on over 130 traditional Indigenous lands. We acknowledge that the home office of AdvantAge Ontario in the city of Vaughan is on the traditional territory and Treaty 13 lands of the Mississaugas of Credit First Nation. We also recognize the traditional territory of the Huron-Wendat and Haudenosaunee peoples. As an association representing diverse senior care providers, including those who are part of and serve Indigenous communities, AdvantAge Ontario is committed to reflecting on our privileges as settlers to make meaningful contributions to the road of reconciliation. Please help me in welcoming our speakers for today, who I am pleased to share the floor with. We have Kathy Peters, who is an experienced health system leader driving integrated systems of care. In her most recent role as Executive Director for the Burlington Ontario Health Team, Kathy has led healthcare organizations serving Burlington to incorporate as a new nonprofit organization with the shared purpose to promote health and well-being for the benefit of the general public. I'm also pleased to introduce Paul Sharman, who was first selected to serve on Burlington City Council as the Ward 5 representative in October 2010 and is now serving his fourth term in office. Since 2012, Councillor Sharman's quest to bring better care to seniors began when his mother had moved to a long-term care facility from a retirement home. He and his colleagues had dedicated much of his time and effort in establishing the Coalition of the Willing in Halton and the City of Burlington to implement and demonstrate that there is a better solution to providing older Canadians with dramatically better quality of care. This was accomplished by adopting the practices and philosophy of the inspiring U.S. program of all-inclusive care for the elderly PACE to produce the now proven and successful Community Wellness Hub model. Thank you, Councillor Sharman and Kathy, for joining us today. And thank you all for joining our presentation. As you may all know, the continuum of care for seniors in Ontario is siloed and incredibly limited for those who are of low and middle income. We are seeing increasing number of seniors over the number of years, as by 2046, the number of seniors will be almost doubled as it is today. We're also seeing increasing trends and statistics projecting the number of adults who will be living with major illnesses in Ontario by 2040 and requiring significant hospital care. As part of this, we're also seeing an increasing need for assistance with activities of daily living as seniors age in order to maintain independence. However, it's important to note that as part of this, unfortunately, Canada's healthcare and support systems have not kept pace with the rapidly aging populations, and we're able to see this as older adults represent 1/5 of the population and account for 47% of Canada's total healthcare spending. Currently, aging in place strategies across the province are based on the assumption of housing stabilities. As you're able to see on the slides, there are three major buckets that really exist for seniors. Long-term care is able to provide residential alternatives for patients with high care needs, such as those who have more mobility or cognitive issues. However, it is estimated that a quarter of those entering long-term care have needs that could be better served in the community. Retirement homes have been a good alternative in terms of providing privately owned residents who are able to provide care and supports for seniors who want to live independently with minimal or moderate supports. However, they are not subsidized by government and could often be very expensive for seniors to afford. Home care has been another alternative for seniors and people with complex medical conditions of all ages in order to support with them living independently at home. However, this sector is drastically underfunded and oftentimes out of reach for seniors. These strategies unfortunately leave out the missing middle of seniors who are looking for affordable options to age independently beyond long-term care and retirement housing. And as you know, the lack of affordable and local options mean that many seniors either have to save put and are underserved or end up prematurely seeking long-term care options and may end up in hospital after avoidable adverse events. Nonprofit organizations spanning health and social and housing sectors are coming together in collaborative and integrated ways to enable older adults to age in the right place. Leadership in municipalities, Ontario Health Teams, and other collaborative structures are key enablers for pioneering innovative models. These promising practices have proven to improve the health and quality of life for seniors who want to remain in their homes while also breaking down barriers to service navigation, accessibility, and affordability. These practices have also proven to delay entry to long-term care, reducing strains to healthcare systems by preventing ER visits and creating better partnership opportunities with local providers. Hence, today we are happy to share insights into the Burlington Made Community Wellness Hub model, and I am very pleased to turn it over to Councillor Sharman.
Well, thank you, Patek. That was a great introduction for the presentation we're going to do this morning, and I'm going to start off with comments about my mother. Surprisingly, not surprisingly, I guess, so many of us have have had to help our parents as they've got older and lived through challenging situations for the very reasons that you mentioned. And that was true for my mom, who started to well, she moved to Canada from Britain in probably 1975, and then she hung out with my family. She worked for the Red Cross. She did a lot of volunteering herself, and gradually, as she got older, she lived in a condominium. We would visit a lot with our children, my sister and myself, and the families. But gradually, she became increasingly isolated, despite the fact that we were visiting, and so it got to the point where she was telling us things like, the boy upstairs is drilling holes in the ceiling, and looking at me and shining lights at me, and that was very, this was the beginning of her own journey, and and at some point along the way, she went along to the local hospital to get some tests done, and it happened to be an outside clinic, and in winter, and as she left, the steps outside the building hadn't been cleared of ice, and so she slipped and banged her head, and that really began the journey in high speed. Um, at that point, she was becoming less able to look after herself, and and she was also, very taken up with the circumstances that she was feeling from her neighbor, and so we contacted a gerontologist, but my sister and I spent months asking ourselves, how do we find somebody to help? Who do we ask? And we didn't know anybody, and Google in those days wasn't that particularly helpful. It was very early, and so we just said, oh, well, gerontologist, obviously the right answer. I'm saying this with deepest regards for the people who dedicate themselves to the health of our elder folks. But we took mom along, and the gerontologist said, oh, she's a paranoid schizophrenic, and I don't know that was any particular a very good understanding of what she was. Some of you might understand that better than we did as lay people. But Mum was given some prescription pills, and 2 days later she was catatonic. This was devastating to us, because it might be suitable, but perhaps in a place where there was a lot of people to look after her, but Mum had no one to look after her, and suddenly she needed, intense care. And we were lucky enough to be able to bring her sister, who was a nurse, from Britain over to look after Mum. And about 6 months later, after we got her off the medication, she resumed, some of her what she was able to do in the past, but in a worse situation. And so from there, she got to we moved her to an apartment in my sister's house up in Bellefontaine, thinking that Mum would be able to cope. And she had her own kitchen, bedroom, bathrooms, living room, all that sort of stuff. But it became clear over time that she wasn't able to cope, and my sister and brother-in-law found themselves providing care. Again, difficult to do, as many of you know. And so we asked her if she'd like to go on vacation to a local retirement home up in Orangeville. And so she said, sure. And we sent her out for a couple of days. And afterwards, when she came back, we asked her how she enjoyed it. She said it was great. We said, good. Would you like to go again? And she said, sure, I'd love to go back. And so we sent her there. And that was when, the story took a turn, because retirement homes don't have the right care, sufficient numbers of people to look after folks who are entering into dementia and need more and more care. And so subsequently on Earth Day, when the lights came back on, Mum was approached by somebody who said, how are you, Margaret? And my mother pushed her out of the way. Of course, Mum wasn't that strong, and that was deemed an act of violence by CCAC. So she ended up moving into a long-term care in a locked ward. And that was, of course, awful. Locked ward where she had young people who had mental illnesses and lots of people were being, perhaps abused by some other folks. It was very, very disturbing. Eventually she got pneumonia on a couple of times. Finally, the third time, she couldn't swallow medication, and it wasn't going to be given. Antibiotics were not given by the needle, and she passed. It was a difficult journey for us all. And we were very upset, of course, but that started the journey for my sister and I to think about what is going on, and what is going to happen to us as well. I mean, what we just seen is not an acceptable story for anybody. And yet we could not see a model out there, any care model, other than you wait till you get unwell, and then you go to hospital and you find yourself where you find yourself. And the question we were asking was, could this have been different? And as we got into it, we found out really it couldn't be any different, because there were no coordinators. To your point about the need for navigation, somebody to talk to about it. Let's face it, basically today it's no different. Older people tend to look to Google to try to find out where to go, and that's not helpful. So my sister and I started off on this journey to try to figure out solutions. And we got into self-help groups and helping organizations where there were lots of buildings where there were lots of seniors to at least create relationships with coordinators, but more to do with social interaction. But it didn't help with getting to the right wellness solution. I use this as an entry to this slide because if you take a look at this slide, what it's saying is that the older population today, over the age of 75, is perhaps 7% of the population of Canada. And that is going to double in the next 20 years. And we know that we couldn't even survive COVID because the capacity of our healthcare systems was very largely consumed by folks with COVID. And we know that there were 90,000 excess deaths in Canada during that period. And really the question is, where is the capacity to handle the doubling of the older adults? We know that the more older adults over the age of 85 has a significant impact on the number of patients in our healthcare system. And really, the question was raised when I was in a conversation with Rob McIsaac of Hamilton Health Sciences, who basically said, you know what, by the time we get to see a patient in the hospital, everything that could have been done in the community has not been done. And this is a call to action, which I happen to believe in. And so I'm just going to put it with that in mind. Upon our, oh, sorry, I got there before you did. With that in mind, it just happened that I was at a conference in Washington on my professional world, and a senior finance person from Chrysler was there, who I'd known for a few decades, and he was now retired. He said, "Here, why don't you come and visit? We've got this very interesting center called Rivertown, and it's operated by the Presbyterian Villages, which is an offshoot of the Presbyterian Church with the United Methodists, and they have 5,000 units of seniors housing, and so we went to visit, and along the way we discovered that in this particular building and a few of their others, they have something called Program of All-Inclusive Care for the Elderly, which basically provides a 360-degree surround service for older adults, and allows them to live in their own homes. And we'll give you a little more detail on that. But it certainly does relieve pressure on the healthcare system and long-term care systems in the United States. And we have nothing like it in Canada of the same set of philosophy. And just very quickly on that, the philosophy was created in Chinatown in San Francisco by a service organization that focused on providing services to those who spoke Chinese only in San Francisco, in Chinatown. But it was built on the Chinese philosophy of respect for elders and caring for them. And so it was very specific, and it was suitable. We'll talk more about that again in a bit. In any event, on November the 8th, 2017, myself and the mayor of Burlington at the time organized a community meeting where we invited community leaders to come and talk about PACE and to think about how whether or not it would be appropriate for bringing it to Burlington. I remember at the end of the meeting, after everybody had finished talking, we had folks from the United States come up and provide their experience and talk about how the model works. And you know, now as at that time it was in 30 states, and they had 400 centers and about 40 or 50,000 people participating. And at the end of the meeting, there was silence, and I stood up at the front of the room and you know, just basically thanked everybody for coming. And just asked one question. The question was, who amongst you thinks that we should not do this? And there was silence, of course. And then somebody at the back said, okay, so what are you going to do, Paul? Let's get on with this. Anyway, so that became the basis, the motivator for us for what we subsequently did. And I want to talk a little bit about that. And in Burlington, after that November 8th community meeting, you know, although we've been struggling, we knew we had a lot of seniors and we had all the kind of problems you're discussing. I was on a seniors advisory committee, and you know, we were already motivated to do something, but we just didn't know what. After going to Detroit and seeing Program of All-Inclusive Care for the Elderly, it became evident that there was a solution that we could be, we could adapt to our circumstances. And after that meeting, I mentioned, we got together with people who volunteered to join us to help define how we might implement it. And we had the chair of the Joseph Brand Hospital, the president. We had senior people from our regional housing and social services, from Habitat for Humanity, even charitable leaders as well as our local Lynn at the time. took us a year to figure out what to do. And then this is where I met Kathy Peters, and Kathy was brought in as our sub-LIN director. And she at the time was given the responsibility for chairing the anchor table, and she can correct me if I'm wrong. But there were a whole bunch of service providers, including the folks I mentioned earlier, as well as EMS and the police and many other groups. Kathy will talk about that later as well. And they had created something called the Burlington Anchor Table. We had a similar meeting that we had back in a year earlier with that team. And again, we asked them at the end if, did they think we should do it? And the answer was yes. And we asked them, would you take carriage of this? In other words, will you be responsible for making it happen under the direction of Kathy? And the answer, delightfully, was yes. And so this is how I met Kathy in that journey. And it's a delight to still be working with her today. Except now we're much further along, and she'll tell you all about that herself, having spent now 6 years working side of a desk, trying to figure out how to get it done. It's done. So after that, we'll talk a little bit more about the success we've had. But we did start I was involved with the region and community housing. We did identify a building where which we owned, where we could put our first pilot project. We spent $1 million on renovating it, the LIN, and the then transformed into the OHT. And at that time, what we now refer to this location, which I would have said was the pilot project, but now as the Community Wellness Hub. It is now the first of many, and we will talk more about that. So I just wanted to talk a little bit about the transition from PACE to the Community Wellness Hub, and then a little bit about how we see this evolving. Fundamentally, PACE in the United States, as I said, is built on this Chinese philosophy of respect and care for older adults. But then it is influenced by the American financial system and the way in which they care for older adults, just in the same way as our care model is influenced by governments. So if we take a look at the target population in the United States, it's primarily low income, although they do have a continuum. They have some market units of housing. Fundamentally, you have to be Medicare and Medicaid eligible. You have to be chronically ill over the age of 55, and you're qualified for nursing care or home level care. In our pilot project, we chose a different group of people. We chose a group of people who happen to live in home community housing in a particular building. Kathy can talk more about the nature of that group of people. But they weren't nursing care eligible. It is assisted housing, assisted living. But there were all sorts of variables and different factors. Fundamentally a different target population. As I mentioned, the funding model in the United States is capitated. In other words, there's an amount of money coming, a fixed monthly amount coming from Medicare and Medicaid, and perhaps private sources, but fundamentally publicly funded, low cost, and many in-kind services. But they are volunteers, which I think we need to take note of and figure out what else we can do. And then you get into private sector versus public sector. Yes, you can get private healthcare in the United States, and it can help you with, for example, all the PACE centers. Most of the PACE centers in the United States are privately owned, whereas what we've done in the Community Wellness Hub is it's publicly owned, that leaves us all sorts of opportunities to think about then how we might adopt the model to a larger audience, and we'll talk more about that in a few seconds. In any event, the notion of PACE is exactly the same as ours in terms of reducing hospitalization reducing emergency department visits and institutional care. And what we are thinking is it will have the same basic objectives, but really focusing on bridging the various services we have, because we already have universal health care. So we want to make sure that everybody continues to get that. But what we do is we keep people out of there longer and have healthier and happier lives in the community. There have just on the concept of PACE-like models. We have a number of colleagues who were visiting PACE centers, a decade before we went, and they figured out what the premise of PACE was in the United States, and then how they could adapt it to their own particular communities. And this becomes a really important factor, and that is context is everything, because PACE and Community Wellness Hub application changes in different contexts relative to the audience, for example, how ill they are, how much care they need. In any event, so Peel Seniors Link, which is part of the Peel Seniors Housing, has been operating Peel Seniors Link for 10 years. They have 380 participants. We're not calling folks patients. They are just people participating in the wellness model. Centre d'Accueil Héritage, a francophone community in Toronto, didn't visit PACE, but they built something like it. And so they will say PACE-like, whereas clearly Peel Seniors Link is PACE-like, but also was inspired by PACE. We would think about our wellness hub as PACE-inspired, but still it is an adaptation of PACE. So what we have is a lot of different adaptations of PACE in Ontario already. We have now 5 in Halton, 2 in Hamilton. Also, we'll have another 3 in Halton in the next year or two. We also know that new communities across Ontario are implementing it in places like Milton, Oshawa, Ajax, Scugog, Peterborough. This is a happening thing, but nevertheless, it is still the same principles of we would say PACE-like models or community wellness hubs, and it will be an adaptation. And there could be differences or similarities, but fundamentally it's about applying a community coordinator, navigator, working with service providers to make sure that nobody has to, basically wait till they're unwell to find out how they can be looked after better. We want to give them the answer. I'm just going to go to my last slide to talk a little bit about the way forward. No, too far. There you go. Part of our experiences, and Kathy can talk a little bit more about the building in the middle, which was a non-community housing building, basically owned by a not-for-profit corporation, very senior, very dense with senior population. It is a NORC in essence, but it's something that we had involvement with at the Regional Halton and also the Burlington Ontario Health Team. And so what we were able to do, what was that, 6 months ago, a year ago, not that long ago, was to create an opportunity for a community wellness hub to be present there. And it's had fabulous results already. The thing about community housing is it provided us the path of least resistance to build these PACE-inspired centers and prove that they are effective and efficient. We have done that. It is now a fact. As we look into the future, the slide on the left talks about the Regional Halton, and we know that we need to find the next path of least resistance to scale the support of older adults in the community outside of community housing. And we know that in the Regional Halton, we've got 126 tall buildings, naturally occurring retirement communities and townhome clusters, in which, at the least, there's 40% density of older adults, but more typically 60 to 80%. In the city of Burlington alone, we've got about 72 of those buildings. So there's also an opportunity to start thinking about how we can scale up the PACE-inspired process and standardize it across Ontario, but also across Canada, because we know that in the course of the next 5 to 10 years, we need approximately 1 million person PACE participant capacity if we want to take the work off or save our government funded hospitals and long-term care facilities from collapsing under the weight. An example of that on Ottawa, for example, there's a 10-year waiting list to get into long-term care. We know that in 20 years we'll need 2 million. The challenge is upon us, but Kathy's going to tell us how we get there. So anyway, that's it for me. Thank you very much for listening to me, and I'll be delighted to answer questions later. Thank you. Go ahead, Kathy.
Thank you sincerely, Paul. A great intro, and really happy to be here today to share the story of the Community Wellness Hub. Unfortunately, maybe not all communities have such a champion in a city councillor as we do with Councillor Sharman, but hopefully everyone can find some champions in their local areas to come together in the way in which we have in Burlington. So yes, I am Kathy Peters, the Executive Director of the Burlington Ontario Health Team. And as Paul told the backstory, this work of, the privilege I've had to co-create the Community Wellness Hub started back in 2018 in a different role, but was able to be carried through in the work that I do today. Next slide, please. Normally, I'm also partnering up with our local housing leader for the first 5 years of this journey. 5 or 6 years, I was partnering with Andrew Ballahura, who was the previous director of housing at Halton Region, and helped co-create this model and this partnership. And now I have the privilege to work with Daryl Cater, who is the director of housing. And so his contact information is at the end of this slide as well, should you want to have that core housing perspective of how we came together in these spaces of health, wellness, social services, and medical care in supportive housing units. So as we've talked about, there are some core principles to the Community Wellness Hub model that we developed over time. And through this, it's truly an alliance of health, I'd add medical care, wellness, housing, and social service providers that come together in a new way that is truly integrated to deliver services for a particular population. We have standardized this model, and it can be customized to your local community and to your local population. I'll highlight the core principles and then go off script a little, but these core principles are essential to the success of the Community Wellness Hub. So it is a focus on proactive, holistic, and integrated care. It also is built off of an interdisciplinary team through redesign of existing organizations and existing staff. And through that consistent team, they're able to build trusted relationships and develop person-centered care through the model. We focus in our targeted neighborhoods on equity-deserving populations. We all know that service and funding is not finite, so we have a focus to get the biggest bang for our buck with this model by focusing on those who are most vulnerable and in need. And we've also proven it to be a cost-effective and scalable model, which I'll share with you later in the presentation. I just want to speak to the proactive and preventative pieces of this model. It's really important in this day and age when many people don't have access to a consistent primary care provider to be able to have a team or a person that can help them not only navigate what they're dealing with, but what might be coming in the future. And we've built a health system that's been reactive, responding to needs after the crisis has occurred. And so I saw this early in my career over 25 years ago as an occupational therapist, working out in the homes and community, where I'd be going into people's homes after they had fallen and fractured their hip. And many times you go in and you say, this was a totally preventable fall had I just been in here earlier. Had I just known and seen the signs of the mobility changing. And I also saw it in other examples of seniors where you get into the home to provide supports and services to a family after the caregiver has already been burned out and truly can't take care of their loved one who has dementia. And we've heard the story of Counselor Sharman and his family and what they went through with his mom. And that happens sadly every day in multiple communities across Canada. And so the question I always ask myself is, how could we prevent these things? And maybe that's my clinical background leading that thinking. But this model truly addresses people's needs as they're happening, but also can prevent because they have a trusted relationship with the individual. They know that individual. There's a longitudinal relationship so they can see changes in that individual and actually keep well people well, help people with chronic disease, manage those diseases, and address those signs and symptoms before they become a crisis. And so we've actually prevented through this model emergency department visits. We've shortened hospital stays, all the things that you want to do at a system level through this preventative and more proactive model of care that focuses not just on the medical, but the wellness, the social isolation, and just living a quality of life where they want to live in their home and in their community. I will also mention a little bit about the targeted population, as Paul brought that up earlier, and how we focused on those equity deserving populations. Seniors often face a great deal of stigma in the healthcare system and often maybe not heard or understand their role and empowerment. And so through this model, we've built it on the pure values and interests and goals of the people in the communities that we serve. So we target neighborhoods and buildings where there are key data metrics that indicate that they're most in need. Those include hospitalization, emergency department, 911 calls, home care utilization, and the marginalization index. And through those metrics, we were able to plot and map all of the buildings and neighborhoods in Burlington that were identified as high need. And from there, we looked at the buildings and who owned the buildings. And many of the buildings were supportive housing buildings. Many of the buildings were owned by Halton Community Housing Corporation, which then became our housing partner. And early on, when we started scanning these buildings, we identified that there wasn't a shortage of services going into the buildings. There was a shortage of integration, coordination, and collaboration of those providers going into the buildings. What we found is over 20 different providers going into the buildings, not communicating with one another, having very fragmented plans of care and goals for the tenants of the buildings, and not communicating with the housing provider or each other or the primary care provider. And so there was a lot of duplication. And so we started by really honing in on what do the people that live in this building need and want by surveying them. We understood their service needs, and then we started to tailor the team around those service needs. And we actually scaled down the number of providers that were going into the building, which allowed for increased capacity in the system. We were able to add a role called a community connector, which I'll talk about, which is an individual that's there 5 days a week and has built relationships with the members of the Community Wellness Hub as well as the housing provider. And we were able to build structures and processes and tools and templates that everyone agreed upon to use, including one consent form, one intake form, one care plan, which anybody who's ever tried to get healthcare providers to change the way they do things and consolidate into one knows that that was a multi-year journey to get to that point. But what was interesting about the targeted population is there were some commonalities within the buildings, but not across the neighborhoods. And we found that when we scaled across other neighborhoods. So 410 John Street, which was our original community wellness hub, had issues of literacy. There was 140 units in the building, 140 tenants, 122 units. And 10 of those units were occupied by people by Community Living Burlington, so people living with developmental disabilities. 20 of those units were receiving assisted living care, and about 30 people in the building were receiving home care. And what we built was a comprehensive suite of services that actually addressed all of those individual needs, as well as those who were living well. And what could we offer them in terms of supporting them through social isolation, maintaining their mobility, etc. And so you build a sense of community within a community that maybe never existed before. And you build a sense of trust and more or less, one team. And that is the motto of the Community Wellness Hub: one team, one member, one care plan. And they've really adopted those values and principles as a comprehensive group of providers, which has been great. I'll move to the next slide, please. So this gives you a little bit of a sense of the team, as well as a bit of the governance. So under the governance of and leadership of the Burlington Ontario Health Team, the BOH team members and collaborators partnered with Halton Community Housing for our first 2 locations, and then we expanded to other housing providers for our 3rd location in Burlington. And we offer primary health care, housing, wellness and recreation, mental health, and system navigation. The glue of the team is truly the community connector that performs the system navigation functions that's embedded in the model. And you'll see that role at the top of the circle. We have a focus on social medicine for those equity deserving populations, tailoring the services to those needs. In one of our buildings, there is a high population that speak Mandarin. And so we've tailored the team to not only have individuals that can access translation services, but also individuals that speak that language, and also the materials for education and socialization are in the languages in which the members speak. We've been able to successfully connect health, social, and housing in a really meaningful way that translates to impact to how people live and how people live well. I don't know who's on the call, but if you are in housing or in health, you often think, how do I reach out to that partner? How do I come together in a meaningful way to help this shared population that we serve? And I was fortunate enough to work with Andrew Ballahura, Director of Housing at Halton Region, who came to me and said, Kathy, our landlords are really struggling in a number of our seniors buildings. They know how to fix toilets. They know how to, keep a clean and well-maintained building. What they don't know to do is manage an individual with mild cognitive impairment who may be wandering in the hallways, or how to support that senior with mental health and social isolation impacting anxiety and depression. And what they wanted to do, not only increase the length of tenancy of the members, but they really do care about the tenants and want to be able to create a home that can be with them till the end of their time. And the last thing anybody wants is to transfer people out into long-term care. But the reality is these individuals don't have a lot of funding or financing. They can't access private services. If they could afford a retirement home in Burlington, you might be paying up to $10,000 a month in rent. So how do we prevent these people from being pushed out of supportive housing because of their health needs, but also how do we help them maintain a quality of life and meaningful life that they deserve. And so it was really great to come together with social service providers, housing, and health to build this model together. We also take a lot of pride in the monitoring and evaluation, which brings us to this slide of the quintuple aim that looks at enhanced patient experience or tenant experience, improved population health, enhanced provider experience, improved value, and advanced health equity. Some of the metrics that we measure are very detailed, and so we have monthly dashboards as well as annual evaluations. And the monthly dashboards look at some of those output measures of how many people are participating, what types of services they're participating in. That helps the individual hubs tailor those services in real time. But we also look at system level metrics like ED avoidance, length of hospital stay, when people who are in the model are admitted, and really great metrics, which is one of my favorites, things that address social isolation, like do you have a friend as a result of the Community Wellness Hub, or have you met a friend as a Community Wellness Hub? And close to 100% of our members answer yes to that one. So that's one of my favorites that I like to share. Moving to the next slide. This speaks a bit more to the health and value outcomes of the model. As I said, we perform a number of surveys of both the members and the providers, as well as system level metrics, and this gives you a little bit of a taste of all of that. Improved self-perceived wellness is at 100%. We have 31% lower rate of hospitalization for ambulatory care sensitive conditions, 14% less or non-urgent emergency department visits, so less urgent or non-urgent. In addition, you'll see the values that we've created with some economic evaluation with our partners at Davis Peer, presented here as well. That looks at hospital bed allocation annually, overall healthcare system costs as compared to long-term care, and also value. Oh, I don't know, I've lost the slide. There we go. Thank you. Value from reduced, less urgent or non-urgent emergency department demand. Next slide, please. With the member and provider experience, this has been something that's been quite rewarding to see, particularly when we have an HHR crisis in both health and social service sectors. And we know individuals struggle to be able to do all that they want to be able to do for the clients that they serve. And so by coming together as a team, we found efficiencies, reduced duplication, as well as improved provider experience, which is noted here in these quotes. I'll draw your attention to the left of the slide. This gives a sense of the targeted population in all of the buildings. As I said, average member income is $20,000 annually. We have 7 languages spoken, and 11% of the hub members with non-English as the first language. So really focuses on the equity piece that we need to focus on to ensure we're meeting the needs of our members. One lady allowed us to share a video of her, and this is a snippet from the video in her describing her experience with the hub, but speaks also to, often the stigma that seniors experience living their lives and being sometimes forgotten, as the words that she states here. She says, "I feel like I belong here. It's very inclusive and good for my self-esteem. I'm recovering my dignity. The hub makes us feel like we belong and we are not invisible and forgotten." Next slide, please. So we've done a lot of work. We've spread to 7 locations with supporting our neighboring Ontario Health Teams on the other side of Halton, Connected Care, Halton OHT, and in the Hamilton area, Greater Hamilton Health Network. And so my team has supported their team and implementing the Community Wellness Hub. And we are now in 7 locations and speaking to about 10 other Ontario Health Teams actively right now. To do this properly and ensure that we're all measuring in the same way, implementing the same values, guiding principles, core elements, we've created a standardized guide in a partnership with Davis Peer, who are a social impact firm. And so this provides step-by-step guidance on how to implement and operate a community wellness hub. It gives an organization or an Ontario Health Team or municipality all the tools, templates, resources, and examples that they need. It outlines here the overview, gives you the introduction to the model. In terms of pre-implementation, it tells you about some local governance structures you could leverage, including your Ontario Health Teams, as well as some foundational partnerships you would need to be able to develop a community wellness hub in your community, and goes all the way into really like specific tools and templates for your ongoing operations, including the member intake form, care plans, evaluation tools. All we ask for in return is joining our community of practice, where we take the collated data and the impact measures and begin to evaluate and assess this model further. We're doing some new work with new populations now, starting in Hamilton. One of the buildings is focused on individuals, again, supportive housing, but a younger population living with mental health and addictions. We believe that the Community Wellness Hub model is not solely for seniors, although we've started with seniors because that is our targeted population at the time in Burlington. But we recognize that the core elements of this can be adopted to any community for any population. And we're also on a journey to, as you saw in the team, the primary care providers in the hub, including a nurse practitioner, community paramedicine. We have a care coordinator in the model as well. We're now looking to expand those more medical or primary care offerings within the Community Wellness Hub to address some access and attachment needs as well. So a lot of opportunity within this Community Wellness Hub model, and we look forward to continuing to evaluate it further to see the impacts it can have on a broader scale. And we have some information here for any organizations that are interested. If you have sparked a bit of interest in the Community Wellness Hub model for your community, you need to evaluate maybe the fit for this model within your community. You can reach out to myself, Daryl Cater, or Matthew Rios from Davis Peer. All our contact information is available here. We'd be happy to help you, and you could scan the QR code if you wish to take those next steps to booking a touch point. We are presenting a broader, more wider workshop on the Community Wellness Hub, both Paul and myself, and we'll be joined by Matthew Rios at the AdvantAge conference. So this is a bit of a teaser. And if you want more information, I believe the conference is fully booked for that workshop, but there's lots of ways that you can learn more, and this is just one. Now, I think I'm passing it back to you, Pedek, for any Q&A. Thank you so much.
Thank you so much, Kathy, and thank you so much again, Councillor Sharman, for you both sharing your expertise and valuable insights. And I know we're coming to the end of our time, so I'm not seeing any questions in the chat, but I do have a closing one for you both. What advice would you give to members who are looking to create wellness hub-like models, but don't know where to start?
You want to go first, Kathy?
Sure, I would. I'll give it a stab. I mean, we talked about the anchor table that I co-chaired. If there is a committee or a table in your community that has a number of different organizations and sectors across the system coming together, then you might want to, join that table or that committee. A natural fit for us is the Ontario Health Team structure. Ontario Health Teams are funded by Ontario Health and the Ministry of Health to support, facilitate, and test and innovate new models of care based on population health management. And many of those tables may focus on seniors or other populations that this community wellness hub model could apply to. And or a primary care table. So maybe connect in with your local Ontario Health Team as a starting point, and they may already have relationships with your local housing providers that you could leverage and begin the discussion and conversation. That would be my suggestion.
Okay, so I'll take a shot at this. I really go back in time and think about what helped us get going was simply a leader who was willing to take a risk and do something outside the box. Because otherwise what we're finding in some communities, which we are involved in outside of Burlington and Hamilton, is there are a lot of people all looking at each other and saying, well, maybe we should do this, and maybe we should do that. But they're all wanting to do what they are familiar with and work within their own rails, if you like, their own lane. And actually, what we have to do is have somebody who's willing to say, actually, we need to take on an integrated, collaborative relationship building of trusting relationships that serve the needs of the individual community member. Rather than just sprinkling pixie dust as we do. And so we can have this and you can have that. What do you think worked? And the answer is, well, maybe nothing, because none of it is what we need. Leadership, drive, and somebody who's willing to think outside the box, and then find people like Kathy who are going to step up and make it happen. Thank you.
That's really great. Thank you so much, both. Really appreciate the opportunity to learn and hear your insights once again. And as Kathy, you had mentioned, we hope to see you all at the convention session where you can have a chance to ask questions for Kathy and Councillor Sharman, which will be on April 30th. So we hope to see you all then. But just wanted to thank you all for joining our session and would really appreciate the opportunity to hear your feedback. So if you have any insights or input to share for any future sessions, we welcome you all to scan the QR code to answer a couple of questions. We also wanted to give a special thank you to our corporate partners, Arjo and Complete Purchasing, for ongoing support. And lastly, just thanking you all again for joining our webinar, and thank you so much again, Kathy and Councillor Sharman.
Thank you very much. Thank you, everybody, and thank you, Vitek and Kathy. I look forward to seeing you soon. See you.
Yes, likewise. Thank you all. Appreciate it. Have a great day.
Thank you. You too.